Great, thank you. Good afternoon, everyone. I can see we've got people beginning to join us now. We'll give it a minute or two to allow people to join, and then we'll get started. And welcome to our digital health webinar. My name is Emily Birch. I am the Chief Nursing Information Officer for the North London Mental Health Partnership. So that's Barnet, Enfield and Harrogate Mental Health Trust and Camden Islington NHS Foundation Trust. I'm absolutely delighted to be chairing this session today, where we'll be looking at accelerating healthcare insights and rapidly unlocking value from your data. And we have the wonderful Rami Ryman with us to go through a presentation and talk to us about some real life use cases and how data and AI can play a pivotal role in helping us to transform our healthcare using real world insights and information. The session is being recorded and it will be sent out to everybody afterwards. We would encourage questions. We will hold a Q&A session after the presentation. Please do use the Q&A function and start thinking through the questions you'd like to ask. Rami, would you like to introduce yourself?
Thank you, Emily, and good afternoon, everyone. So happy to be with you all, and thank you for joining us today. I'm a medical doctor by profession. I'm an oncologist by specialty. I joined the health informatics world 8 years ago. I currently cover the EMEA region, Europe, Middle East, and Africa, and I look after the healthcare business from electronic medical records, health information exchange, AI, and looking at ways to make this more useful, more helpful, and solving more healthcare problems in general. As part of today's presentation, what we will be looking at is a common theme we have seen all across the world, and specifically in the region where I cover, where people want to solve problems, healthcare problems, and the way to reach there. How fast can we reach that goal, or how fast can we reach that outcome? And we will focus our presentation today in real-world practices around getting there and how to solve that particular problem. I'll start off with sharing my screen, and we'll walk through that presentation together. So when we talk about healthcare in general, and before I start with the story in here, a few things around my role. As you know, I work in the whole EMEA region. So naturally, I travel a lot for work. And the last 2 to 3 weeks, I've visited around 6 countries because we had a lot of events. And in one of the places where I have visited, these are my 2 daughters, by the way, I was in, like the hassle with kids in secondary and primary schools, education, helping them with homework. We ended up doing most of this remotely because half of the time I'm not at home. And I was in Rome Airport, in Da Vinci Airport, 2 weeks from today, on Friday, like last 2 weeks. And we were on a Teams chat on an iPad. I'm sitting and grabbing dinner before taking my flight. And the girls are arguing with me around some homework they're having. It was a science homework, and they're trying to understand the different formats of solids and liquids and gases. And the message was not getting through. I wasn't in the right mindset, and we couldn't achieve what we want. So they were insisting for them to allow them access to go to YouTubes and things like that in order to finish their homework, because they didn't want to leave it. And naturally, over the last couple of years with their iPads, we had all those restrictions put on as parents in order to protect them. And in my head, I was so focused, like, no, this is not the way. We need to do it together. And long story short, I caved in and I agreed with them. I allowed them access. I looked what they wanted to do, and I let them go do it on their own. And by the time I reached home that evening, I wanted to check how did they do. And the excitement on their face was unbelievable. They were really like, they found a nice video and they learned from it a lot. They really grasped the topic, and they were very ready to have our movie night without wasting it. And that took me to think about what we see in healthcare all through the days today. We sometimes focus too much on the process we have put in, on the rules that we have set in, forgetting the outcome that we want to get out of it. And sometimes that hinders us in achieving what we want to achieve. And it really hit from that simple lesson I learned from the girls and in what I see day to day in healthcare. And that's why I'm telling you this story today as a starting for what we will walk through it. So in healthcare, we look at healthcare problems, general ones. We look at fixing medication errors, overuse, misuse, antibiotic resistance, like more complex problems. We look at public health issues. We look at surveillance, communicable diseases. How do we monitor it? How do we make sure we don't have disconnected social care and medical care joined together? We look at the logistics of admissions and readmissions, and how do we keep patients away from the hospital longer, keep them healthier for a longer period of time. We look at things like patient condition management, things that are simple. People who are newly diagnosed with hypertension, for example, it's crucial to keep an eye on them when they start this new treatment. But they go home and we don't see them the whole time, and they spend sometimes a couple of months before coming back and figuring out that that treatment is not optimal or that treatment is not the right treatment for them. Similarly, for pregnant patients, during that normal majority of the 9-month period, if you don't do the right precautions, the right measures, the right monitors for the patient, you can end up with a lot of comorbidities and a lot of preventable diseases or preventable complications that could arise. Similarly, for post-surgical care. If we look at chronic diseases in general, being able to identify the risk, being able to identify who's at a high risk, who's at a low risk, who could benefit from prevention is extremely crucial. We look at how do we put a care plan for a chronic disease patient that can span the GP, the hospital, the primary care, the social care, the nurses outside. And these are like typical problems that arise wherever we go in any healthcare sector. And these are the problems all of us in the healthcare field are trying to solve. We go even beyond that into resource utilization. We always have shortage of staff. There is no country in the whole area where I work where we don't have a shortage of staff for the medical field. So we need to know, how do we manage the resources the best way possible? How do we make sure the right people are at the right time in the right place in order to be able to do it? How do we manage costs in order to keep the bill low, no matter who's paying, if it's the government or the insurance or the patient? We need to be cautious around that. And then moreover, with all of that data in place, how can we leverage it safely, protecting the patient rights, protecting the patient identity, yet utilizing all of this data to be able to generate better researches, get better breakthroughs, and get better treatments overall. So these are the general problems we usually look at. And these are the things that we put all the technology setup that we set up in order to reach that value over there. In short, the technology is no longer limited to a single EMR or a single system or a single health information exchange, but it's a little bit more complex to something around all of this screen that you see in here. It's a mesh. They call it today data fabric or a smart data fabric. So here we're talking about multiple sources of data coming in from a variety of sources like devices, registries, labs, even the police or the EMRs. Combining that data, making sure we identify the right patient, making sure we harmonize the data, and then reusing that data into the care community, for example, with the rest of the clinicians, into the patient, or being able to do analytics around it, are common themes that we are looking into as we proceed with this digitalization. So moving from that, having all of that in place, the traditional history is that people go step by step and they need to put every piece of the puzzle before they start reaching the value. And in general, this took years before you could reach out to the outcome. And I'll walk you through a couple of cases and how we have shifted from a mindset of setting up the technology and looking at everything all together to focusing on smaller problems and reaching the value in a quicker time or in a faster time to reap the benefits of this technology that's coming in. The first example is probably one of the largest health information exchanges in the world. This is from New York in Northern America. And in 2020, they had 20 million patients. Today, they have more than 26 million patients within the records. But just to give you a sheer volume around it, we have thousands of hospitals, 22,000 physicians, so many healthcare providers joined in. And in simple terms, after the years, it's been around 15 years, 16 years, they started this journey. And after they coupled the data and got the data in and worked so hard into getting it, it's only the last few years that they started reaping the benefits out of it. They got in patient alerts. So you could see in here, we are doing around 7.3 million alerts per month on average. And these alerts started to span things like admission to the hospital, overuse of medication, vaccination records, missed vaccination. In COVID, it became very helpful in order to be able to put in all the picture of the COVID scenario that was brewing. This data helped them to be able to pinpoint which hospitals, which areas are at a higher risk and work on it. And then they reach eventually to a step where on their unified care record, they could predict a patient index. This is a demo patient, but this is a patient index, patient risk that's immediately available using all of this data to tell you the risk of this patient having an MI or having a diabetes problem or comorbidity arising, or having to come to the emergency for a revisit. And if we take this extreme of the story, around 15 to 20 years period to get to the outcome, on the other side of the world, in the United Arab Emirates, we embarked on a journey to be able to put in a health information exchange for two areas within the country. And the story was slightly different. The story in here was, we want to get to the value, we want to get to the outcomes as soon as we start having data. We don't want to wait until everyone is onboarded to get in there. And in here, we took this whole journey from the 20 years or 15 years into a 2 years where we have enrolled patients and get them on board. So NABID is the Dubai Health Authority Health Information Exchange. We went live, we onboarded all the hospitals, 220 hospitals within the first year before we started taking the clinics on board. But in their mind, the first outcomes that were there was a digital disease registry, for example. So that was immediate. Within the first 3 months, we started producing disease registries. We helped them working on medication processing and e-prescription in order to identify misuse of medication right from day one. They wanted to even extend this to make it into an innovation hub where Internet of Things can come and safely access data that does not identify the patient, that is completely protected, to be able to produce better applications in the healthcare world. And this is an example of the shift in the mindset where we have changed the approach to get to value in a much faster approach. Now, that's on a large scale when you are connecting data from multiple sources. In different parts of the world, we had examples more focused. So there was a high-profile murder, for example, involving a patient with mental health problem. It highlighted the immediate need to have a mental health record joined together so that people can immediately identify people at risk or people at the risk of self-harm or harming others. East Midlands Ambulance Service, for example, is being able to utilize data from multiple sources to be able to know where this patient is better taken to. So if the patient is coming in with a stroke, for example, which hospital do I take them to? I might have a nearby hospital, but they might not have the right capacity to treat this patient. I might take them to a hospital a bit farther away, but that can get the right treatment for that patient. So being able to do that became immediately helpful. And these are like simple solution-focused approaches that we started doing. In France, in Toulouse, we have a large cancer center, and that large cancer center have a cancer hospital, which treats patients with cancers. And then they have another 2 hospitals that treat the same patient for every other disease. So you can imagine the patient going back and forth between these hospitals, and they need to have a unified care record that can get all of that data in one place is extremely crucial. And that's what we have done. And there are other examples from around the world to do that. Moving forward, Northwell in the US had a particular problem. So in the United States, when you admit a patient to the hospital, you predict the length of stay, or you say, I want to admit this patient for 3 days, and you submit for this in order to get your money back, basically from the healthcare, like from the payer that you are paying. And they used traditional tools with all the big data in order to do the accuracy of predicting the length of stay. And the accuracy was a 35% accurate. That's it. But immediately 6 months after starting their project with unifying all of this data, we started using ML, machine learning, in order to predict a better outcome. So in here, we looked at 6 tables, different elements from the patient record, something like 25 columns and 22 billion raw data elements. We got a good ML model algorithm in place, and that today has shifted the accuracy of the length of stay to 84%. That's not a simple help for the organization. This is a $10 million a month effect on that organization. It's a significant change. This money could help for improvements, for better healthcare, for new staff members, etc. So it's really significant for them. Now, moving from there, another example is to be able to link different organizations into one portal. So today, the patient might end up with a portal from hospital A, and another portal from hospital B, and another portal from hospital C. And in here, the payer, the insurance company in this sense, is saying, my patients are losing treatment, or they are ending up with complications from combining the wrong treatment because simply they are missing their information. And the way to help them is to be able to provide one output for the patient that connects and route messages from different sources. As simple as it sounds, this helped the patient comply better with their treatments, help the patient comply better with understanding their disease, and be able to do better in general. Now, to get a little bit more focused into an example of where we are going and where we have also shifted our mindset, I'll give you the example of population health management in general. So diabetes is something that's well known to many people, and we have good treatments. We know what are the preventative rules or measures we should put in. We have programs that we spend millions of pounds and dollars all across the world to battle it, yet every single year the prevalence is increasing. We have younger people getting the disease, which means we obviously are missing something. We obviously are not doing, there's something still wrong in the process. And within that approach, a mind shift came into place in order to do things differently. So we started by looking, if we have this data, and that's exactly what we had. We had the data collected from multiple places. So we were able to produce, for example, the history of the patient, what the patient is having, the diseases, the other comorbidities. We were able to look at things like BMI in here, and this is an example from a demo patient, but this is exactly how it's being used, where we've identified the history of the patient, and they have a family history of diabetes. We've identified a high BMI. We've looked at their lab results, and we've identified a high HbA1c. And naturally, this data is readily available, but it took someone to log into the systems in order to understand it and put all of that information together. We decided to take it a step further. So what we decided to do is be able to produce an active decision support from all of this data. So we're leveraging a logic in the background that analyzes this data, that we have a set of rules, and basically sending active real-time notifications for the right care providers to tell them this patient might be at risk of having diabetes because of XYZ, because of the reasons they are there. And then we could put in a recommendation to start them on a diabetes care plan, and then start the care plan. And this is where you could start the care plan in here. And here we are bridging GPs, primary care centers, secondary care centers, care coordinators, payers, and the patient, and this is what the patient would see, all under one umbrella of care for that particular disease. So the patient here can see their same data, their same details, but they can also see that they are enrolled in a care plan and start actively adding and contributing to that care plan so that they can do better. And this is the collaboration that was in many cases missed in order to do better around it. But that's not all, because once we have all of that in place, then we could visualize that. Then we could give this back in order to analyze. Is program A better than program B? Is the patient doing well? Are we missing certain patients or not? And this is an example of that population health management, where we could see a specific disease like diabetes split by risk scoring. This is the Cambridge risk scoring, where these patients come from, the mortality from those patients, which hospitals they were enrolled at, and the number of new cases versus old cases. Important data that becomes readily available, so that we don't waste time generating this data, but we spend the time in order to see what do we do next with this data and how do we proceed from that point onwards. And that took us to a step even further. With all of that data in place, retrospectively analyzing data was one piece, but being able to use AI logic and ML logic to produce more became crucial. And that's what we have done as well. So we took all of that, we took our knowledge in the area, and two years ago, approximately 2.5 years ago, we started doing packaging those solutions to fix particular problems. So we looked at healthcare AI, and we looked at packaging it across the 360 spectrum, so that if we build an AI, we need the end user to use it as well. We don't want it to remain dormant. We don't want it to remain in the drawers. We want it to be active as an active part of the healthcare and the well-being of our patients. So what we've done, we've taken sources of data into an instance where we have built the logic using Python and other standards. And then basically we could analyze the logic with ROC curves, confusion matrices, etc. So this is where the science comes in. We make sure the mathematical computation is right, the logic is correct, and then make sure that we use an output back to the source, so that the person at the source, the end user, can benefit from it. And in that example, that's exactly what we have done. For the diabetes example, this is what we have worked on. So in the diabetes example, here you could see healthy individuals. So these individuals are healthy individuals, and this is the general population. And we looked over a period of time. This is a 5 years in number of days. And we wanted to identify which of these patients has a higher likelihood of becoming diabetic, because we are not all at the same risk. We wanted to see who's at a higher risk to becoming diabetic. And these patients were used in order to be enrolled back into that system in order to do better prevention and enroll them into better setups. If we go to logistics, we have a hospital that does 1,000 appointments per day. It's a tertiary hospital for the eyes. It's an ophthalmology specific hospital. And their biggest problem was a wait list of 3 months and a 27% of no-show to the clinics. If you can imagine, out of 1,000 patients, up to 270 people don't show up to their appointments. That's a wasted time for their staff, for their doctors, for everyone who is working in that facility. And over the years, they created so many rules. We did alerts, messages, double SMS, and they ended up calling half of their patients every day to try and make sure they are coming in. And then they ended up putting a lot of overbookings. But the problem is, on some days, everyone shows up to the appointment, and then you ended up with a very busy clinics where no one is happy and the patients are not satisfied and everyone is overworked around them. So we've done a logic using AI, tabular AI, and we've run an algorithm to accurately predict the no-show for those patients. And that's exactly what we have done. And to cut the story short, what we have helped them with is reduce the number of calls to only 150 instead of 500. We helped them add 50 new overbookings, but these are targeted overbooking against the higher percentage of people that will not show up. And overall, they managed to save 25 man hours every single day during this process. And yet we are to see how that effect will be on the waiting list for them. And in order to do that, we have bridged that step, which is very important. This is the call center people when they are trying to book a patient. They immediately get the outcome of that logic. So we have agreed with them on 70% and above to show up. This is a demo, so I'm showing it for a lower number. But it's basically saying everyone who's above 70%, they get an alert against them. Anyone with more than 90% chance of not showing up, the call get transferred to the supervisor so that they can really discuss it with the patient and ensure that they will come in. And also we added in an icon in here to let them know that this patient is high likelihood of not showing up. And this is where we can do the overbooking for it. So we brought it into the normal workforce, into the normal workflows that the users are using and be able to use. And in those examples, we did a couple of clinical use cases. Antibiotic resistance is still theoretical and it's under a POC with the government in the UAE. We looked at exacerbation of asthma, for example, so being able to predict the exacerbation or having an asthma attack before it happens, being able to look at an early sepsis detection. We've looked at administrative tasks, which are extremely helpful. In the same organization, we predicted the surgical procedure time. So in this facility, they have 4 operating rooms, but they do 100 surgeries because they are ophthalmology surgeries and they finish quite rapidly. So even saving time for them, being able to predict the right amount of time to book means a better utilization of the resources. And we've improved their utilization by 12% in doing that. We've looked at predicting the lab sample rejection rate or predicting the inpatient length of stay, as I have explained before, and even looking at things like the revenue cycle, DRG discrepancy, or predicting expensive stock usage, etc. in there. And then the era of generative AI, the likes of ChatGPT came in, and that's where we started also looking, how can we safely use the large language models into the healthcare today? And things like creating claims report or handover reports or operative reports or GP letters is something under research and development, and we're actively looking at it. We have doctors from around the world testing this in order to see how it will work. But it became very interesting to leverage this kind of technology to battle things like even security of the data or identifying breaches by putting a logic to analyze the system constantly and be able to understand it and be able to collect large volume of data and produce it. And the last piece of what I'm talking about is to show you this in practice. So this is what we are thinking of. This is where in our systems, we are bringing in under what I said is like the research and development is bridging in the same tool, the power of these generative AI tools. So in here, you see a patient, Diana Fraser. We have protected by not sending the name of the patient to the logic. So we're not sharing the name of the patient, but the logic is pre-prompted to analyze the data. And immediately, for example, here, the system can produce a summary of that patient and a subjective, objective assessment and planning setup. So all of that data, all of that structured data that's coming in, we could easily bring it in. And in order to make it more user-friendly and more available for vetting, we added in tabs, as you can see in here, to link back to the system. So if I want the patient summary chart, I could easily reach out to it. And then we all know, for example, the better quality of care that you can produce to your patients is to be able to link to evidence-based medicine and use the latest evidence-based medicine. So here is an example where this tool becomes very helpful by asking what are the recommended treatments and then seeing how do we do this for like cholecystitis, for example, for this patient, and what do we do and how do we make sure the patient is doing better. And that's not enough because bringing this in contains a risk of having hallucinations or having the wrong data coming in. So we made sure that the source of information is readily available, where this data is coming from, where did the logic bring it from, so that the user doesn't need to struggle to find out if this is correct or not, but be able to bring it straight away. And then there are things like being able to do calculations, medical calculations, things like an ion gap, where the system will pick up all the needed elements from the lab results, like the sodium chloride. And this serves as a good tool in order to double check your recordings. So you do your calculation or your own system is doing calculation, but then you can do a check around those calculations. And then again, you'd be able to use this data in multiple ways, being able to look at notes, for example. And many of us write the 2 pages, 3 pages around the patient history. But with time, if we have, let's say, 100 notes, it's very important to be able to produce a summary of that note readily available for people to read. And that area that you are interested in, you can dig deeper. So the area in these fields are becoming huge. There's a huge potential of really saving time, of really helping users by removing the redundancies and reach out to that value more, whether it is generative AI, whether it is tabular AI, or whether it is a good streamlined workflow like for the population health to reach that goal. So similarly, what we are saying in here is that in order to be able to achieve the success you want to achieve, you need to derive value, and you need to derive value as fast as possible. It's very similar to my story with my kids. It's really the same, because we sometimes are stuck by thinking, no, this is the only way to do it. And we never stop to rethink the whole process or to rethink our regulations, and regulations are changing anyways, in order to be able to use what technology we have today to a better use for us. And the recipe for us has become very simple. Simple to say, it's not always easy to accomplish, but it is attainable if you have the right setup. And usually, if you have the right partner, you are cloud ready, you are interoperable, you have a solution focused team, and then your immediate team is value driven or value oriented and agile. Put the two together, and then basically this is how we have achieved most of what we achieved before. And we could see by numbers that we have improved the patient safety, we have reduced costs, we have improved healthcare overall across the areas that we have worked. And that's basically our message. That's what I'm passionate about, at least, and that's what I look after. And I hope I'll open now the floor for questions so that we can discuss this more. Thank you.
Thank you so much. That was incredibly interesting, and I've written down a ton of notes from that. I'll take please do everybody use the Q&A function to ask your questions. I can see they're already starting to come through. So one of the first question that we have is, do you see generative AI being integrated with InterSystems solutions? If so, what are the most prominent use cases considered?
So generative AI is still under research and development. What you have seen is already built from our side, but we are taking a lot of considerations into place. So the couple of considerations that we are putting into place are patient safety, regulations. How do we vet that the generative AI is correct? One of the problems of generative AI is that you don't expect the outcome that comes out of the generative AI. You're relying on a tool that have learned large language models, not necessarily for clinical data, but that we are using it over there. So we are taking it very carefully in terms of which use cases do we say, yes, let's go ahead, and what rules and regulation do we build into the system to protect the misuse or the wrong use of this tool over there. So as a tool, it's readily available, but the research and development is mainly around those areas. At the starting point, the main focus is user experience. How can we make this much easier on day-to-day work for the user to make it easier? If I want to find certain information, collecting it and bringing it in front of you is something that saves you a lot of time. If you have 100 patients a day, that's saving you already an hour or 2 hours by doing that. So these simple things. Other one is repetitive tasks that you fill them in, but the AI put it as a package in a nicer way. So for example, you write your bullet points or your notes around your lab results and the patient, and you just want to write a quick referral note to the GP to tell them, this is what I've done to the patient. AI does that very well, and the generative AI would do that very well for you. So that becomes really helpful. In places where you have to submit to government or to payers reports in order to get your money back, this is also a tool that can help the organization be able to do the right coding, the right documentation, so that you can submit your numbers accurately and be able to do it over there. In all of that, a lot of vetting, a lot of careful observation of the outcome is still needed. We cannot completely depend on this blindly, but it shaves a significant amount of time. It takes me much less to review a certain data rather than having to produce it and then send it off. And then there are ways also to use AI itself to double check the output. So you can ask them to do a report, and then you can take the original data and the report and ask the same AI to double check if this is correct or not. And it's quite interesting to be able to see it. So there's a lot that we're investigating in that place.
Thank you. That's really helpful. And I suppose that checking, as you've described, sort of helps to support managing potential unconscious bias that might already be in data sets or within our healthcare system. Something which I know, especially within mental health, we struggle with. A question from Susan. Could you use the generative AI to create discharge summaries for patients?
That's absolutely one of the use cases. The immediate use case that we're looking at it, which is very similar to a discharge summary, is something that we're actively looking at, is a claims submission form. So in places where you have insurances, you need to submit basically like a discharge report or a medical report to the organization to tell them what happened and the justification for it in order to get your money. So that has been working quite well, but certainly the system can learn to do discharge summaries and tailored discharge summaries. So discharge summaries will differ with the context. If you're sending a discharge summary to another doctor is one thing, but if you're sending it to the patient themselves, the content slightly differs, and that is an area that the AI would do well on. And then furthermore, referrals would also be easily handled by doing a referral report. And another area from that perspective, it's not a summary for discharge, but when staff do the handover, when nurses do handover or when doctors do handover, the system can learn what do we write in these handovers and be able to produce your handover note for you in a faster way.
Thank you. And sticking on this theme of use cases and where generative AI can be used, we've got a question. We saw examples of healthcare. Could this be used within dentistry as well? Is there limitations on this type of technology?
So the generative AI piece, as I said at the beginning, is not medically specific. It could be used anywhere. It's basically a large language model. It analyzes large volume of language, like written data, and be able to understand it with time. That's the power of it, is that being able to put the relational ship between the different data and put it in. So in the dental context, it will learn the dental context of the tooth number, the decay, etc., and be able to produce it. In the general healthcare, it will do the same. In the mental health, it will do the same. And then in logistics, for example, something away from medical field, it will do the same. The rules will still have to abide the same way. It's a tool that people will need to learn how to use. It's not straightforward because the way that you prompt the AI makes a big difference on how do you get the output out of it. So in one of the examples I haven't shown you today, but we prompt the AI by saying, I'm a doctor, I'm a nurse, I'm an oncologist, I'm a cardiologist, and it helps shape the way the answer comes back. Also, we can say the answer needs to be concise, or the answer needs to be long, or the answer needs to be in bullet points. So you can prompt the AI after you start using it over and over. It's important to do that level of training so that you know exactly what kind of output is coming out of the AI. Otherwise, if you just start blindly, you'll sometimes find answers that don't really make sense to what you want, and that's a challenge that you need to work with in order to be able to get to that output.
Amazing, thank you. And again, sticking with this theme, we've had some really good examples. Do you know when these features will be showcased or more generally available, when they move past this research phase and we can start looking at how we can implement that into our own systems?
So all the use cases that you have seen, the ones that are not involving AI, are live cases, and they are already there. The tabular AI use cases, the cases for the clinic no-show, the cases for the antibiotic resistance, the cases for the diabetes prediction, the cases for predicting the operating theater, these we call them tabular AI or non-generative AI. These are controlled. So these we feed in the data. So we know which data we're feeding. We kind of know what output to expect. But we run a neural network, for example, or we run logistic regression or whichever tool that makes sense, and we do the output. Those, we have 2 customers live, some under POC, some under like really live in a live system that's using. Those ones are readily available today. The generative AI piece within the system, but we don't have a specific date, but it's very soon. It's something that we are anticipating for next year to be readily available if all the legalities are around it. There are still requirements sometimes beyond us with the local authorities and with the local regulation bodies to have a concrete framework that we can all abide with. So we've built this framework with the tabular AI using our knowledge of like MDR and what would be required before you can build a system like that. The problem is you still don't have a clear regulations in place. These regulations are being built in Europe, in UK, and the US. Some are a little bit more comprehensive, but it's getting there, and we are getting ready for it. And that's a way forward to look at it.
I think we'll all be keeping a close eye on the news next year to see how these things are worked out. We've now got a selection of questions specifically around some of the use cases you showcase to us. So from Paul, really interested to hear what data was used to predict the do not attends and the no-shows. Sort of how did you come up with that data set?
Okay. So originally, when we built them internally, luckily we have in our teams people who worked in, like I'm a clinician, we have a couple of other clinicians, we have admin staff from hospitals, and we have the technical team. So our team knows how things work in general, but we also partnered with our hospitals that we work with to get it in. For every use case, we've identified the use cases or the data elements that needs to go in order to do the logic. And then sometimes that data elements was not enough, so we need to expand on it, or we need to improve it by adding extra data elements. So if we take, for example, the clinic no-show, we looked at the patient age, demographic, gender. We also looked at things like, why are they coming for the visit? Is this a new visit or is this a follow-up visit? Because sometimes the follow-up visits have a higher chance of no-show compared to the first visit. We've looked at the proximity to the hospital. So for example, where do they live? Do they live in a place that's close to the hospital or far to the hospital? And apparently it also had an impact on predicting the likelihood of coming in. But in that particular example, after going live for 3 months now, we've even enhanced it specifically for that hospital because it's an ophthalmology hospital. And out of an experiment, we took over the prescription level for their glasses into account to see how they will show up and not. And it makes sense if you think about it, because if people have a higher prescription or a new prescription that has happened within the last few months, they are more likely to stick to their appointment versus someone who's stable and doing well and they will not show up. So it depends on the use cases, but we've looked at these kind of elements. In the operating theater, we looked at the comorbidities of the patient, the CPT code of the procedure. So what's a procedure that's happening? We looked at who's the surgeon that's operating on them, how many staff members are available, if there's a special equipment or not. And we learned from that history with these data elements in order to say, okay, Dr. X with patient Y for this operation, you need to book 12 minutes. But for someone else, same thing might end up with 18 minutes. And this is something learning from the previous data and bringing it over. That's why tabular data is a little bit more accurate, more controlled as an experiment versus generative, but you get these kind of results that you can control and play around with.
That's really interesting. Within any of these data sets, are you building in any social care information? So I'm sure many clinicians will know the statistics around mental health and learning disability patients. They are less likely to attend their appointments, but have a higher risk of these comorbidities. So understanding you just spoke about 12 minutes for one appointment and 18 minutes for another. Are you building in information to support reasonable adjustments, disabilities, or social care and safeguarding challenges?
Absolutely. In our system, we call them alerts. So if someone has a disability, we place an alert so that everyone knows that they have this particular disability, and these are playing a role in our logics. In the US, social determinants of care are also very important, and they are playing a role in the logics they are building for like reporting, for analysis, for research, and in the AI use cases as well. So it's definitely playing a role in it. We're taking into place, even locally, without the AI in the analysis perspective, the can't remember the correct terminology for it in the UK, but we're basically also looking at the socioeconomic statuses of these patients, because it can correlate to their contribution and their compliance with their treatments, and compliance with getting the right treatment as well. So we're putting those kind of data together, not necessarily with AI, with the analysis, but it could also be part of the AI as well.
Oh, really exciting. And I know Susan is really interested to understand what the diabetes predictive score, what metrics were used to support that.
So the example that I showed you is based on the Cambridge risk scoring. So the Cambridge risk scoring is one of the scoring system. This takes in, let me try to remember, this takes in the body weight, age, comorbidities. It takes in if the patient has a family history or not with the diabetes, their blood sugar, like the random blood sugar value, blood pressure value, and a couple of other factors. It's a forgive me if there's something I missed around that, but it's a risk scoring. You basically say all of these elements, and they are scored, and if you fit within the score, you end up with a score 0 to 5, 5 to 11, and then above 11. And above 11 is considered risky, and then there's category of the risk over there. It's a well-produced one. You might have a nice guideline that will do this, so it's the same thing. For us, it doesn't really matter. The data and being able to play around the data in terms of doing this kind of computation is what we care about, because then you can have it, and this becomes your cohort. This becomes the cohort of patients fitting into this criteria, and automating that process. So I don't have to calculate for every single patient. Having it automatically done and adding the patient to the right category is what we care about. And then you can continue from there to continue whatever you need to do.
And how is it? So all of this information, all of this data, it sounds like it creates a really amazing way to help us drill down into our patient needs, support population health promotion. But how is this information communicated back to service users, back to the citizen, so that they can start using this information to support and empower themselves?
Absolutely. So the particular example on diabetes is the example around that, because typically we had the statistics. We knew which patients are under which category. And then we know that there were patients on certain protocols, because those hospitals have placed those patients on a specific treatment protocol or specific preventative care protocol. But what was missing is, what did the patient do those other 300 days when they are at home, which we never saw. And then there are areas where there are community nurses or community workers that are also part of that loop that are not coming part of it. And this is where, for example, the care plans come in. The care plans is beyond a specific EMR or a specific system. It's simply a tool. And you say, this patient is on a care plan. The care team members are social worker, nutritionist, the GP, the doctor, diabetologist or endocrinologist from a hospital, and the patient. And all 5 of them have access to the same care plan. The patient accesses the same care plan. Each person puts their contribution to it and sees the output in the same way. This way, you see everyone on the same page. Everyone is understanding. Everyone knows that the information is related. And the next time you see the patient, you don't spend the time asking them the questions that you already have the answer for. You just go to the next level and work with them. And that's a proposal. We tried this one with population health preventative care in the Dubai Health Authority. This is what they're using their health information exchange to be able to do. And that's where we're going with it. But there's also several examples from across the world for different use cases. In Germany, early next year, we will be launching this same solution with the Diabetes Association. And it's only for this particular solution. So this is bringing in everyone for diabetes in one of the regions in Germany, and hopefully we're taking it to the rest of the country, focusing on that particular disease as an example.
Wow. So I'm sure, as everyone can hear, this is really powerful and big stuff that can reach everybody, not just in silo in our local organizations. One of the questions we have is around anesthetics and intensive care units, and how this technology and AI can be used to reduce maternal mortality rates?
So in those areas, we're starting to look at things like sepsis prediction and early sepsis prediction, for example, in ICUs, being able to analyze large volume of data coming in from your monitors, from the patient, from examination of the patient, and putting it together in order to early detect deterioration. So we know, like in ICUs, we have several well-recognized measures that we do in order to predict the patient getting more sick, basically. But it's sometimes difficult to be able to compute it for everyone and to compute it on regular basis on 24 hours, for example, or on hour by hour percentages. Electronic medical records are good at this and they tend to do it, but there's always a gap on top of it. An example of that gap, for example, in sepsis, we've built the logic on static data, on discrete data. So we've taken like vital signs, blood pressures, etc. But we figured out that wasn't good enough, because sometimes a nurse's note is equally important to say that the patient was feeling a little bit nauseated, they were not doing well, they felt dizzy, they felt weak. These kind of words, they are not discrete, they are not something discrete in the logic. So what we have done is we've used our language model, not a large language model, to build in a glossary of items from free text, to combine it with data that we typically would do in discrete data, and to put the two together in order to predict on outputs. And these are the examples you can use in anesthesia, in the operating room, to determine if something is going wrong, and being able to join two different technologies, analyzing language plus discrete data, and help in those computations in real time, something that we see going more and more. There are areas which we don't do, but they are readily available, things that will analyze ECGs, like the continuous ECG monitoring, and help you with the readings. There's very good use cases today on imaging. So the imaging, people who do imaging, like the PACS, and they do the radiological images, they are very powerful in analyzing disease and analyzing early pneumonia, early infections, early cancers, etc., better than the human eye, and they are widely used. So there's a variety of things that could be used, not necessarily just like EMR data, but data even beyond it.
Fascinating. And when I think about that free text, I think about how multicultural our healthcare services are. How is language models and compensating or working with potentially the fact that maybe English is not first language, or in other countries where you will have multiple different languages, and maybe the way that people interpret or write down information in free text? How is it managing that and pulling all of that together?
That's very interesting. So as you probably gathered, I don't practice full-time anymore. I just dedicate myself to this, but I run a pro bono clinic back home every 5 weeks with a collection of doctors. So I go in for a weekend and we just see 80, 90 patients and leave. And we use free text. We don't have any good system over there to use because they have limited resources, etc. And we started experimenting around 7, 8 weeks ago with generative AI over there. One of the use cases is producing a patient instruction in Arabic, in the language that the people would actually speak. So we do everything in English, but we do the output in a different language, or in French, or in any other language that you do. And that took me to start experimenting and looking at it in Germany. A couple of weeks back, we did the experiment we have an English system, but we prompted everything to ask in German, get the answers in German in real time, and everything else is in English. So these language models work very well with cross-language analysis. They particularly do well in understanding common language as well, like the sense of the wording. It's not like a literal word-for-word translation, but understanding the notion and putting it in the right way. And that's a very good place to expand on the generative AI use down the line.
Fantastic. Thank you so much. And we've got time for a couple more questions. So we have from Vlad: would you use your own proprietary model or an open source LLM?
We're doing both, to be honest. So the Where we need a specific output or a specific target, we are preferring to use our own language model, like the sepsis case, because I'm very targeted on specific things and I want to use them with discrete data in order to build a different model out of it. But where we are talking around summaries and there's a lot of differences between user preferences and what they can do, a large commercially available language model is good enough. Now, to keep note of that, these large language providers, whichever one it is, ChatGPT or anyone else, whichever one you choose, they are aware of the necessity of being able to put rules in perspective. So in the example that I have shown you, there is a clear regulation that we don't share, for example, the patient names and identifiers. The language model does not keep any of the data of the patient within that large language model that they are using. So we can bring in publicly available information, but they cannot use that instance data into it. And this is part of the regulation. This is part of the things that we are legally looking at in order to make sure it is in place so that nothing, you don't risk a breach, you don't risk a need to expose data that you don't need to expose or make that data publicly available, but you can utilize it in that instance and be able to use it as you proceed.
Fantastic. And it's really interesting. And I think it sparked huge amounts of conversation. And thank you to everyone who's submitted questions. Just like to end on pathways for clinicians. So obviously you've moved into this world as and working with data scientists, etc. What pathways, what advice would you give for those of us wanting to come into this world and do more research and more work around data, AI, etc.?
My path was totally coincidental. It wasn't planned at all. I never thought I'd end up in this place. If you'd asked me a couple of years back, and I still miss the clinical work. Today, luckily, we have a lot of digital buzz, a digital move where many of our systems are in the verge of changing their digital technology or utilizing their digital technology forward. You have a couple of pathways. Either get involved within your organization, ask what they are doing, and simply get involved, because us as a vendor, we always depend on the counterparts from the hospital, and the more the merrier. And this is how we proceed, and this is how we do it. The other one is there are a lot of initiatives, startups, studies, and researches that vendors do. So vendors like InterSystems or others are working in. So on their websites, you'll find a lot of information around which area specifically you'd work on. There's a lot of data science companies that work with data if you're just focusing on data and getting out of it. Data is something interesting because the European Parliament is setting up a new regulation around secondary use of medical data. And that is expected to make a big change in the way that we can use patient data under anonymized, randomized data, but being able to use it in structures like open source OMOP structures and do more research, more outputs out of it. So those areas are becoming very important. And I think they are readily available everywhere. You'd be surprised, even in your own organization, if you ask, you'd find something is going on. And I would say that's an easy way to start experimenting and then see how that will drive down the line. And then there are a lot of webinars like these or events worldwide with HIMSS, with CLASS, with Gartner, etc., that they do that are worth attending and checking the outputs out of it.
I would also add within the NHS and within the UK, there is also our digital academy that offers things like the Topple Fellowship. It offers a wide range of educational support and courses as well. So please do check that out. Thank you so much, Rami, for your time today and for sharing all of this information with us. Really fascinating and really, really exciting. Thank you to everybody who has joined us today as well, and for all your questions. This will be available on the Digital Health website, and the recording will be sent out to attendees. Thank you so much, and have a wonderful day, everybody.
Thank you all, and thank you, Emily, the most for being so attentive and taking care of all the questions. I really appreciate it. And thank you all for attending with us. It was my pleasure being with you. Thanks.